No, but we'll see if we can get that information and provide it.
You just said you were going to change the definition. Can you tell us a bit about that, or when would you like to do that, and what would make that happen?
Yes, so the technical advisory group did meet this morning, and I specifically asked them to look at the definition, given that we now have evidence of some community transmission. The key thing I wanted them to look at is whether we decouple the symptoms that form part of the definition from the requirement to have a travel history or to have been a close contact of a confirmed or probable case, notwithstanding there was already that ability for them to test someone even if they didn't fulfil those criteria. So that would be a key change. I'm just waiting to get that advice, and I'm expecting that later today.
And are you also considering other forms of testing? Obviously, they're talking about doing fingerprint tests and things like that. Would the government take any alternative testing into consideration?
We're looking at all the different testing modes that are being looked at and developed overseas, and in fact we've got a particular stream of work on looking at both the current testing, which is the PCR type testing to diagnose, which identifies the virus to diagnose the illness. There's also some work happening internationally around antibody testing to see if people have had the infection post hoc. The latter is much less well developed. There are also different ways of testing, like rapid testing and so on. We're looking at all of those actively.
We're testing about 1,800 on average, and got the capacity to test at 1,000, and you're hearing from people like Sir David Skegg, who says that the testing is misleading, we need to be doing far more. Professor Nick Wilson, who's also saying we need to do far more. Why can't we test at capacity? Why not loosen the criteria sooner as well?
So I think the important point here is capacity is not a constraint on our testing. And so what we do want to do, as you've said, and as I think Professors Wilson and Skegg agree with, is we want to find all these cases, because then we can take the appropriate action. And that's specifically why I've asked the Technical Advisory Group to look at that definition to make sure that it is not constraining testing the right people and finding positive cases. Perhaps two more questions, if that's all right.
Was 10 days before the COVID-19 cases picked up here. How significant could that cluster be, and how many cases do you expect to see out of it?
Say how many cases we're expecting, but yes, that means there was quite a period of time for the index case, the first case, to have a number of close contacts. So hence there's a big effort going in to trace and isolate all those close contacts and to test those who need testing. It's very important to be extremely thorough in these sorts of situations. One advantage is that it's localised, different from, for example, the Hereford Cattle Conference down in Queenstown, where people dispersed around the country. It's much more difficult to contact, trace and isolate people. So we still have very low levels of what we think is community transmission based on the testing that's been done. We're revising the definition when we think it was appropriate, and also we want to make sure that professionals out there, our GPs and those working in CBACs know, and they have been since the 14th of March, been able to exercise that clear clinical discretion. And my sense is we've done over 21,000 tests. It's clear there has been a lot of testing of people who haven't necessarily fulfilled the epidemiological criteria, but the clinician felt that it was important to test them.
So, we've talked about the CBT being particularly vulnerable. Is there specific information and advice going to those communities, given life expectancy, given overwhelming negative statistics about some low health areas? Is there really sort of specific detailed advice going to those communities around this?
Yes, there is, and there's quite a large effort going in around both those communities. We've got several advisory groups that involve both health professionals who are providing that advice, but also linkages with key community leaders, iwi leaders for Māori and so on. So yes, and there is already quite a lot of information on our website about the initiatives that are happening there, and I can say that that's a big focus for our work. Look, thank you very much.
If I can just say, Joe, it's also worth noting that we're embedding iwi liaison into the regional emergency coordination centres, so that we're making sure that alignment with iwi partners is tight between health but also emergency management, outreach into networks right across the community.
Thanks very much.
Yes, so this work is all joined up with the general approach to welfare services.
Thank you very much, and we'll see you tomorrow.